All right, you're free to start whenever you're ready.
All right, I'd like to welcome everybody to the Lymphoma Committee. I'm Jonathan Friedberg, Chair of the Lymphoma Committee, and we have a very interesting, packed agenda for this Friday afternoon. I hope your weather is sunny and bright as ours is. I know we all long for meeting in San Francisco, but maybe there's some degree of optimism we'll be gathering in Chicago in a few months. I wanted to just start by showing this data cut that was distributed with the meeting materials, really demonstrating how lymphoma accrual has improved significantly over the last few years. This is really a testimony to our hard our working group who's been working so hard on developing new concepts and studies that are of interest. And as you'll hear today, we have some new studies that will be opening and have just opened that I think will only increase this further. And for a disease like lymphoma to be ahead of GI and lung is really remarkable. And I thank all of you for your active participation in our studies, your accrual, and your continued interest in the Lymphoma Committee. I'm now going to turn it over to the Vice Chair, Dr. Sonali Smith from University of Chicago.
Hi, everyone. I want to add my very warm welcome to our open meeting for the spring session of SWOG. I want to share Jonathan's wish that we could all be together in San Francisco. So as we just heard, Lymphoma Committee has been really busy, and I'm really excited and proud to work with the group that we have. You're going to hear from some wonderful speakers talking about the work that they're doing. And perhaps I'll just start by introducing our first speaker, Dr. Deborah Stevens. So Dr. Stevens has been a part of our committee for several years. She is currently faculty at the University of Utah. She had done her internal medicine residency at Cleveland Clinic, fellowship at Ohio State, and at University of Utah, she's really established herself as an expert in CLL and lymphoma, and currently is the physician leader of the Hematology Clinical Trials Division at Huntsman Cancer Institute. We've really appreciated Debbie's work ethic and contributions to our group and have asked her to address some of the challenges and rising issues with CLL. So I'll turn it over to Debbie.
Thanks, Sony, so much for the introduction, and thanks for asking me to speak today. Really, the title of my discussion today is called Defining Risk in Chronic Lymphocytic Leukemia. And part of the reason why I was asked to give this presentation today is because we just opened up the S1925 study. And part of this study is really the enrollment in this study is all about being able to define a patient's risk. And we're going to get into the specifics of that. As you all know, in this group, chronic lymphocytic leukemia is the most prevalent adult leukemia, and the clinical presentation is quite variable. And so, as you know, some patients are able to be observed for periods of time prior to therapy, and some people are quite sick at diagnosis. Over the years, many prognostic factors have been identified that can explain this variability in clinical presentation. I, by no means, have time to focus on every single one of these risk factors that have been identified, so I'm really going to be focusing on ones that are pertinent to lead in and introduce my study, the S1925 study. So I'm going to say I have a few slides about clinical risk and more slides about molecular risk. Also important is that some of these risk factors were developed a long time ago. As you'll see, if you look at some of my citations, some of them are actually from the year 2000. And so some of these risk factors have been around for a long time. However, the treatment of CLL has changed a lot during that time period. So we've really gone from non-specific chemotherapies to targeted therapy during that time. So we have our first polling question. And it is, do you feel prognostic factors are important to obtain at diagnosis for patients with CLL? I think you guys have 30 seconds to answer this yes or no question, so take your time. Okay, great. And I don't know if you all can see the results of these, but the majority of people answered yes, they feel like prognostic markers are important. So the next question, I'm curious, which molecular markers do you check in patients with CLL at their diagnosis? Would it be A, FISH for deletion 17p, B, IGHV status, C, TP53 mutation, D, karyotype, E, A and B, or F, all of the above? Okay, it looks like the time limit has expired. I can't see the results yet. Okay, here we go. It looks like most of the respondents selected all of the above. Some people are just getting FISH or IGVH status, and there's a few people that just get karyotype or TP53. So perfect, I'm gonna move on with my presentation. So some people ask me, so why should we check these risk factors at diagnosis? A couple of the reasons and kind of the theme of this presentation is really to be able to educate patients about their estimated survival times and their predicted times to first treatment. They can potentially also guide how often a patient should be seen in your clinic. For example, for me, patients with low risk factors, I can see them on just a once a year basis, whereas people with higher risk factors, I often see them more frequently, at least once every 6 months. Also, it's really important in tailoring therapy to patients when the therapy is indicated, which is what's recommended by the NCCN guideline panel. And of course, as I already alluded to, the clinical trial that we just opened really focuses on these risk factors for inclusion. So first, a few words about clinical risk. It's not a surprise to anyone that the age at your age at diagnosis would affect your survival in CLL, and generally patients older than age 65 are considered higher risk in terms of lower overall survival. We have a few studies looking at this, not many. This study featured on the right was a SEER database study from 1997 to 2011, showing how age impacts your survival after CLL diagnosis. This was prior to targeted therapies being approved, and so these data are a little bit outdated. And so I wanted to focus on some more updated data that show how age affects prognosis in the targeted therapy era. This is really a small study of a larger group of patients, so retrospective multi-institutional study, which looked at patients who are receiving therapy with ibrutinib. They compared survival between patients younger than age 65 and older than age 65 and actually found no difference in survival. However, you can see that the survival curves do separate here, and there are some limitations because this is a short follow-up for CLL patients. It only goes out to about 2.5 years, and more data are really needed to fully understand the impact of age in the targeted therapy era. The next risk factor, clinical risk factor I want to briefly touch on is rise stage. Most of you know how to calculate this. It's based upon blood counts and physical exam. These are just a couple of studies highlighting how rise stage can affect your prognosis. Over on the left, rise stage 0 is the black line that's at the top. On the right, of course, you can see rise stage 0 coming out with extended overall survival here. And as the rise stage goes up, the survival gets shorter. So really just a few words on those clinical risk factors. They do contribute to overall survival. They're important to consider when selecting therapy. Maybe over time, we're going to see that these are less important in the targeted therapy era. Some things that I think are still just equally as important in the targeted therapy era are more lab-based or molecular risk factors. As I highlighted before, the NCCN guidelines do recommend that some of these risk factors be checked at least prior to initiation of initial treatment. These are FISH for deletion 17p, TP53 status, and CPG stimulated karyotype and IGHV status if it hasn't been done previously. One that I want to highlight, beta-2 microglobulin. I like this one because it's a nice factor that can be checked in most labs. This correlates with disease stage and tumor burden. And it may be that it's regulated by exogenous cytokines, including IL-6, which can prevent CLL cell apoptosis. And so that's why biologically this may correlate with survival. Generally, greater than 3.5 is considered poor prognosis, but you can see in different studies, different values are assessed. And over on the right, you can see that beta-2 microglobulin less than 2 has the lowest risk, and greater than 4 has the highest risk. This is a factor that is variable over time, and so often I just check it at diagnosis. IGHV, or the immunoglobulin variable heavy chain, I think is probably one of the single most important things that you can check in a patient at diagnosis, because I think it really gives them an idea of survival. It gives them an idea of their time to next treatment. There are a lot of theories about why this marker in particular makes patients at high risk. There have been some theories that this means because unmutated is the higher risk version, that this came from a less mature cell. But there are also theories about the normal B cell hypermutation. And in general, I think what this marker shows us is just that the cells have a higher proliferation rate in the unmutated copy of this gene. And so, so patients with unmutated disease are expected to be more aggressive. Essentially, when we're checking for this, we're looking at DNA sequencing for homology to the most similar germline gene. Unmutated is diagnosed if there's greater than 98% homology. About half of patients have an unmutated copy, half of patients have a mutated copy. I've highlighted way back from 2000 when this was originally found as a marker. It showed that mutated patients had an expected survival of 25 years, which I think is pretty darn good considering that a lot of these patients are diagnosed in their 70s. Whereas the overall survival predicted in unmutated patients was 9 years. There's also a difference in time to next therapy. In this study, they quoted that mutated patients would take about 10 years till first therapy, whereas unmutated would take only about 3. And this actually does not change over time, so it can be checked anytime during their CLL treatment course. Of course, this is a marker that has changed with the introduction of targeted therapy. You can see I've highlighted a couple of really important frontline studies done in the CLL population. On the left is the CLL-8 study, which looked at standard chemoimmunotherapy. The green marks the IGVH mutated patients. You can see their progression-free survival was significantly longer, regardless of FCR versus FC. And then you see over in the middle, the EA1912 study. This graphic is specifically for the patients with IGVH unmutated disease. And you can see that the patients treated with ibrutinib in this study had a significantly longer progression-free survival at 3 years compared to the FCR arm, which is the gray arm that you can see there. And then also even with venetoclax and obinutuzumab on the far right in the CLL-14 study, you see that the IGVH unmutated and mutated patients receiving venetoclax, which is featured in green, are almost overlapping. And the theory is that these IGVH unmutated patients are much more responsive to B cell signaling, and that's why the proliferation rate is much higher. And so with these novel agents, we're doing a lot better job at blocking the B cell receptor signaling. And so that's why this likely is, limits the predictive factor of this marker. So the take-home point says this is very important in the likelihood and timing of treatment. You can tailor frequency of clinic visits, and there's really a strong preference for targeted therapy in these patients that have unmutated IGVH disease. Of course, FISH, most people have access to this testing, and most people test for it at diagnosis in CLL. I've listed here just the prevalence of these markers within CLL patients and the genes that are affected. I really want to focus on deletion 17p, which is found in about 7 to 10% of newly diagnosed CLL patients. Because of course that spot on the chromosome is where the TP53 tumor suppressor gene is located. And so it's really important as a prognostic and a predictive marker, as your body's DNA repair mechanisms really need this TP53 gene to help their body repair, and that's specifically important after chemoimmunotherapy. And so these patients have a much shorter survival when treated, especially with chemoimmunotherapy. Go back. And this is a really interesting graphic because this is the donor article that was published in the New England Journal of Medicine in 2000. You'll note that the solid black line is the deletion 17p patients, and even over time this has improved, but you'll still notice that the solid black line often is very steep and represents the 17p patients. Again, these are important frontline studies for CLL. In the FCR arm, this black line over at the right-hand side, those are the 17p, showing their shorter progression-free survival. In the middle is ibrutinib, and although this is much better than what we saw with FCR, you can still see that the 17p patients, which is again the black line, separates out at a shorter progression-free survival even with the targeted agents. Over on the right, you see what happens with venetoclax and obinutuzumab, and the green arms are the venetoclax and obinutuzumab, and the solid one is the one with 17p. So there is a difference in how patients do with venetoclax, although this is in general much better than with standard chemoimmunotherapy. TP53 aberrations, again, they go along with deletion 17p. Again, it's a tumor suppressor protein. Likely around 10% have this at diagnosis, and it still does show a predictive and prognostic factor in the targeted therapy era. These curves I'm not going to spend too much time on because they look very similar to the ones we just saw with deletion 17p because there's often a lot of overlap here. Complex karyotype is an interesting and I think still evolving prognostic factor. And why we do a karyotype in addition to FISH is that 25 to 37% additional abnormalities can be detected after FISH. The current definition of complex karyotype is 3 or more abnormalities, and this has been associated with poor prognosis, and this is even in the ibrutinib era and targeted therapy era. As you can see on the right-hand side, the complex karyotype patients treated with ibrutinib, the yellow line is the steeper survival curve there. Of course, I need to mention some recent data that was published that call into question that potentially we should be using greater than 5 aberrations in the karyotype as a prognostic factor, as you can see with the kind of the pink line here. They also mentioned a specific subset of patients that have trisomy 12, trisomy 19, and then another abnormality as being actually a particularly favorable compared to other people who have been noted to be unfavorable with 3 different abnormalities. And so I think that this definition is still kind of evolving at this time, but it makes sense that the more chromosomal abnormalities, the more likely this disease has been to mutate. So the take-home points, these are highly interrelated, deletion 17p, TP53, and complex karyotype. They do have a high impact on survival. They're both predictive and prognostic, as you saw in those graphics. And so how do we bring these risk factors together? Well, I think a nice way to do this is the CLL International Prognostic Index, and you can see the scoring listed here, with the highest impact being from a deletion 17p or TP53 mutation. A score of 4 or higher is considered high on this risk, and about a third of patients are in this category at diagnosis. Here I've just shown the survival based upon your CLL-IPI score. The very high group, or 7 or higher, is this red, very steep survival line, and the high risk is the purple line, which is the second steepest curve there. Also, I think very useful to use this to predict time to next treatment, because you can see in the high risk group, so a score of 4 or higher, at 5 years, only 23% of these patients have not met criteria for therapy. And so, it's a really good tool to help patients understand, what comes next. Of course, many additional risk factors have been identified, and continued research will identify more in the future. I don't have time to cover all of those today. What I did just want to spend a slide or two talking about is what's the current practice right now in the country. And this is data from the Informed CLL registry. This is the largest prospective observational registry of CLL patients who did receive treatment during the novel targeted agent therapy. And the thing I want to bring your attention to is, at diagnosis, only 28% of patients in this database had FISH testing, and only 11% had a TP53 mutation or IGHV status checked. And then, even though I showed you the data, how much better people do in the unmutated category with targeted therapies, people who did receive a standard chemoimmunotherapy agent, a third of these never had their risk factors checked. And so, I think that's important in counseling patients of how likely you think they are to actually respond to the therapy they're being recommended. So again, why check prognostic factors? Really to educate patients and potentially guide how often you should see these patients, to tailor your therapy to patients, and consider enrollment on clinical trials. So the CLL-IPI score is really important. Only patients who have a score of 4 or higher are going to be included on this upcoming study. So I think we'll go ahead and open this polling question back up. I think most people thought prognostic factors were important, but just want to see if I changed anybody's mind, if you feel prognostic factors are important to obtain at diagnosis for patients with CLL. All right, great. Everyone thinks that they're important. I'm very, very happy about that, because really what I want to kind of tag onto my presentation is more details about the SWOG CLL S1925 study. This is a randomized phase 3 study of early intervention with venetoclax and obinutuzumab versus delayed therapy with venetoclax and obinutuzumab. You can see that there are several folks in the SWOG group that had a lot to do with planning of this study. They're listed below, along with the ECOG and Alliance champions. This study, as I mentioned, it's intrinsically important that you know what their risk factors are. And these patients need to be newly diagnosed, asymptomatic, patients with a CLL-IPI score of 4 or higher, or complex karyotype. And we are using the 3 or more genetic abnormalities to define that complex karyotype. These patients are stratified between high risk and very high risk, and randomized 2-to-1 to early versus delayed therapy. The venetoclax regimen is given how it was given in the CLL-14 study, which is to say that you have 6 months worth of obinutuzumab combined with venetoclax, and then an additional 6 months of venetoclax thereafter for a total of about a year of therapy. Just wanted to highlight a few important eligibility criteria. These patients need to be diagnosed within 12 months, and they must not require therapy for CLL by IWCLL guidelines, must have received no prior CLL-directed therapy. They cannot have GI malabsorption, as venetoclax is an oral agent. A couple of notes about this study. This study was finally activated in December of last year. We do have a planned amendment that is under revision right now. One important thing to note is that there is a mistake in the protocol that looks like a bone marrow is required at registration, but it is not. It's only required pre-treatment. So if a patient gets randomized to delayed therapy, they do not need a bone marrow biopsy up front. There is a memo accompanying the protocol to clarify this until we get this amendment passed through. Another thing to remember is all the drugs are provided free of charge for patients on both arms, which I think has been really exciting for patients that when I've talked to them about it. The other thing is we do have some flexibility. I know a big thing on everybody's mind is what about the COVID vaccine? When can we get it? And you know, how would enrollment in this study affect us? And one good thing about this is we have about a month between screening and randomization. And so, and then we also have 14 days between randomization and actually starting therapy if they get randomized to the early intervention. So they have really about a month and a half to get vaccinated, get both the doses of their vaccines. And so, you know, that has been important to some of the patients. I have a list of some of the sites that are open. I had to submit these slides a couple weeks ago, and so there are actually some additional sites that are open. But I'm really excited because we've accrued 2 patients at University of Utah, and we have a third one that signed consent this week. So I'd be really excited if you guys could all get this study open and you know, make sure you're letting everyone know how important it is to check those prognostic factors at diagnosis to know if these patients are candidates for the trial. And I believe this is my last slide other than a summary. So happy to take any, I don't know if we're doing questions now or just moving on.
Sorry, thanks so much, Debbie. That was really a great overview of, you know, how to approach a patient with CLL from a stratification perspective. I share with you the excitement about this trial. You know, this is a group of patients we always struggle with. You know, we know they have high-risk disease, and yet if they don't meet the clinical criteria for therapy, there's angst both on their side as well as ours. So this is, I think, a wonderful study of new and targeted agents. There is one question from Anusha. What would be the relevance of IGVH mutation in the targeted therapy era, considering that we will not be using it for treatment decisions, and based on evolving data, this may be irrelevant in regards to response when we are using BTKI or BCL2?
Yeah, and I think that's a great question, and really, I think we chose to use the CLL-IPI, which does include that marker, just because I think it's the most comprehensive marker. I think patients who have unmutated IGVH, this is a great study for them to go on to because, you know, I think we have the best chance to get the deepest and earliest remissions possible with this therapy, especially in patients in that group.
Dr. Stevens, real quick, if I can. You've enrolled 2 patients on this trial, and you're having a discussion about giving, you know, substantial therapy for a period of time versus no therapy. How did you accomplish that discussion, and how did you engage patients, understanding they, you know, the 2 different arms are so different, at least initially?
Yeah, and I think it's really important to get these people right at diagnosis and tell them, you know, hey, we're going to check your prognostic factors. if you're low risk, great. We have the opportunity to observe you for a long period of time. If you're high risk, we know you're going to need therapy soon, and you might have the opportunity to enroll in this clinical trial with these, really good agents. And I think when people kind of have wrap their mind around it right at the very beginning, they're very excited about it, because especially just as Sony mentioned, if we find out they're high risk disease, that makes them really anxious to wait. I know, my first patient that I enrolled, he was very excited because the drugs were paid for, and he knew, he had very high risk disease, and I think he would have needed treatment fairly soon anyway. And so, this is a great benefit to him financially as well. And, sometimes I think, just my experience with treating these first patients, when people have really low burden of disease, their risk of tumor lysis is so much less. We have so much less disease to get rid of. It was like the easiest induction therapy I have done, because there's not much, to lyse when you start. And so, I think, potentially at least those upfront side effects are going to be a little bit less in this patient population.
That's actually a really, really good point. Waiting till people have high tumor burden is a little unsettling. So there's a comment from Dr. Persky about, broadening the eligibility criteria, which I know has been brought up before. And then Hildy has a question, and then I think we're going to need to move on, which is, are you comparing anxiety with quality of life surveys for the patients in observation versus early treatment?
First I'll respond to Hildy's question. And yes, we are comparing, anxiety and, intolerance to uncertainty, and other, also just, side effect profile. So looking at, our patients who are on therapy experiencing a lot of side effects. And so that's an important component of this too. And Dr. Persky, I hear you. I would love to get these patients on that have been diagnosed for longer. I think, that kind of came, as a mandate for us to have this restriction. And part of it is our primary endpoint is overall survival. And so, if we've had a patient that's had CLL, for 10 years and goes on this study, there was some concern that that would affect our, rates of overall survival. And so I think we'll see how accrual goes. And if accrual is going really slowly or stalls, I think we would have good reason to go back and ask if they could broaden that.
Great.
So
I'm sorry, go ahead, Jonathan.
I was just going to say for the next speakers, the control is going to be centrally, so you just have to say next slide when you're ready. And I think the thought is to go pretty quickly from one study to the next, but also still have some time for discussion and interaction at the end. And we may ask people to help introduce themselves, just to try to keep things moving.
So why don't we go to the next slide then?
Hi, everyone. Hi, Sony. Thanks for having me. So for those of you who don't know me, I'm Brian Hill from the Cleveland Clinic. I appreciate the opportunity to interlope in SWOG Lymphoma Committee. I usually sit in the ECOG Lymphoma Committee, but I've been part of SWOG through the Leukemia Committee for some time and been involved with Debbie in the S1925 trial. And I'm happy to say that we signed our first patient this week for the EVOLVE study. And it was an easy conversation with a patient who was very anxious about her high-risk disease. And she wanted to go on because she wanted to, I would remind the audience that it's a 2-to-1 randomization. So 2/3 of the patients enrolled will get immediate treatment. And if they don't get immediate treatment, they get standard of care. So I'll be brief and represent the Alliance, AO41702, which is the ongoing trial for older patients over the age of 70. This is a randomized phase 3 study of ibrutinib plus obinutuzumab versus ibrutinib plus venetoclax obinutuzumab. And if you go to the next slide, you can see the study chair is Jen Woyak. and the other representatives are indicated. Next slide. So the primary objective of this study is to compare PFS of the doublet versus the triplet. So the ibrutinib, obinutuzumab, followed by continued ibrutinib maintenance versus triplet. And then as you'll see on the schema, there's an MRD-guided treatment decision. The secondary endpoints are to compare MRD, CR rates, and depth of response, overall survival, as well as safety of the two regimens. Next slide. So here's the schema: previously untreated, patients with CLL who have a treatment indication. This is for patients over the age of 70 who are randomized to ibrutinib obinutuzumab versus the triplet, and there is a stratification based on 17p. If you advance one slide, I think you'll see the next step. There we go. So this makes it look more complicated, but if you just focus on the top, there's basically a continuation of ibrutinib regardless of MRD status. And on the bottom, if you achieve MRD undetectable state and are in complete remission, you discontinue all therapy, whereas if you have MRD detectable after the 12 months of combined treatment, you continue ibrutinib. Next slide. The eligibility are pretty straightforward. A good performance status. Of course, your blood counts are actually can be pretty liberal inclusion criteria, and even lower if it's due to marrow involvement, standard organ function as indicated. Next slide. And this shows the accrual. The accrual that I had as of the submission of the slides was 273 out of the target of 454. So the study is ongoing, and I think that's my last slide. Maybe you could advance. There we go. The target is 454, not 54. Otherwise, we'd be done. So that's it.
Great. Just a quick question for you, maybe, Brian. That you know, some patients, have been reading about ibrutinib toxicity, and they're concerned about that because acala and zanubrutinib have a more favorable profile, especially in older patients. Is there any discussion about swapping out the BTKI?
Yeah, I think this obviously was launched well before frontline approval of acalabrutinib, and of course hindsight's 2020. And if you could redo it, you may be more interested in a next generation BTKI. I do share your concern about the cardiac toxicity in this patient population. There are, you can stop if you have a toxicity from ibrutinib, and you might say that an advantage here is that if you're randomized to the triplet, there's an opportunity for complete discontinuation of BTKI after 1 year. And there is some AFib risk with acalabrutinib as well. So it's not a risk of zero compared to chlorambucil in the registrational trial.
Great. Thank you. Yeah, and Debbie has a good, okay, why don't we, next slide?
Thank you.
Yeah, thank you so much, Brian.
Yeah.
Nice to see you.
Good to see you.
Hi, my name is Maziar Shadman. I'm from Fred Hutch University of Washington in Seattle, and I will very briefly update you on ECOG study 9161, which is another randomized trial for frontline CLL here for a younger population, comparing ibrutinib and obinutuzumab as the standard arm to ibrutinib, venetoclax, and obinutuzumab as the time-limited arm. Next slide, please. So we have the key eligibility criteria. I would only highlight the differences between this study and the one that Dr. Hill just mentioned. This study does not include patients with 17p deletion, and this study is also not MRD guided for stopping treatment. So in the experimental arm, the total duration of treatment is 19 cycles for ibrutinib, venetoclax 12 cycles, and obinutuzumab 6 cycles. In ibrutinib, ibrutinib is given indefinitely with 6 cycles of obinutuzumab with the primary endpoint of PFS. Next slide, please. Just points out so it's actually a very timely presentation. Today is the last day of enrollment for this study. The accrual goal was 720. There was a discussion to increase it to 1,000, which did not happen. And we're staying at 720, and I consented my last patient yesterday, and depending on where you live, you have between 1 to 4 hours to consent a patient if you're interested. And otherwise, we'll wait for the results to be presented and published. So very quick accrual and kind of an easy study to enroll patients on. Just going back to Dr. Smith's comment, it was more recently, it's become more difficult to convince patients to take ibrutinib, but the way I approach it is if ibrutinib causes any problem, we have many ways of switching him to other BTKIs, so they're not limited or stuck on this protocol. So that's it for me.
That's fantastic. I mean, congratulations on such a rapid accrual. I think this is going to be a really exciting study. Okay, next slide. Okay, we get to switch to recent activations, and really excited to introduce Dr. Liz Brem to present S1918. I think she'll give you the date, but we are going to have an official kickoff meeting separate from this group meeting later in June. And I hope everybody gets a chance to look through this trial and open it. So I'm going to turn it over to Dr. Brem.
Yes, hello. I believe as of yesterday, we finished the date. It's going to be, I believe, Tuesday, June 29th. So put it on your calendars and we will virtually kick off S1819. So I want to spend a couple of minutes just reminding people, next slide, please. Why we're doing a study in this. So we are looking at older patients age 75 and older with newly diagnosed diffuse large B-cell lymphoma as well as a few other related histologies. And the reason we're focusing on this is because nearly 30% of our patients with diffuse large B-cell with lymphoma fit into this category and are often either under-enrolled or excluded from clinical trials. Next slide, please. And if you look in general, most of you have seen this slide before, but the top line there is depending on what study you look at, that 85 to 90% or 70% are younger patients. And if you look at the single arm phase 2 paper of our mini CHOP, which many people kind of use as their standard in this population, we have a 2-year PFS of 59%, which of course is lower than the younger populations. Next slide. So there was a wonderful recent issue of JCO, and I'm sure Dr. Friedberg could tell us exactly which week it was, but there were 2 really important papers in that issue. And one was the senior study, which looked at a fairly similar population that was in 80 and above in their study, where they took lenalidomide and added it to our mini CHOP. And they did not, unfortunately, reach the primary endpoint, which was 2-year overall survival. But in a wonderful commentary that if you haven't read it by Dr. Smith, I really encourage you to take a look at it, that there's a lot of reasons that may not have been the case. Perhaps it wasn't the right agent, perhaps there was some selection bias, and there's a few other things that we could talk about that perhaps there was a reason that study didn't reach its primary endpoint. And I think the other thing to point out about that study is it didn't use any specific geriatric assessments or other tools to either select or kind of stratify patients, which limited what we can learn from that experience. In that same issue that published the senior study, they also looked at a tool that we're also going to use here. In this case, we're calling it the Elderly Prognostic Index, or EPI, that was developed by some of our Italian colleagues that stratifies these patients into groups, low, intermediate, and high risk, that do correlate with outcomes, and perhaps in the future, if we study it, may help us select therapy or select which patients should get kind of combined chemoimmunotherapy. Next slide, please. And so this is the overall schema of S1918. Not much has changed here, but essentially, again, diffuse large B-cell lymphoma or a few other related histologies, including 3B follicular. Patients will be randomized 1-to-1. We're going to have 3 stratification factors, fit versus unfit, based on that. In this case, I'm calling it the FIL tool, but it's the same tool that was mentioned in the previous slide, is that Elderly Prognostic Index, whether or not patients have transformed lymphoma or their IPI status. And the 2 arms are CC486 or oral azacitidine with our mini CHOP or our mini CHOP alone. And again, we're really excited because this is the first time this population has ever been studied in a randomized fashion in the US. And this is a great example of the power of the intergroups. Next slide, please. Okay, so this is kind of a unique feature of the study design if you haven't been along for the ride for the development of this. And so we're going to have a 40 patient safety lead-in, and this came just to make sure we don't have any excess toxicity with the addition of the CC486. These 40 patients during this lead-in period will have bi-weekly calls, and if everything goes well, those 40 patients will then become part of the phase 2 component. The phase 2 component, the primary endpoint is 1 year PFS. There will be a brief pause after we've rolled 130 subjects, and then if all goes well, then those patients will all roll over towards that phase 3 cohort, where the primary endpoint would be 2-year overall survival. Next slide, please. So we have presented this study several times kind of in its development and gotten a lot of great feedback from people. So I really wanted to take a moment just to highlight what's different or what is new in the kind of activated version compared to what we may have shown you before. So one thing that's important and unique is that all patients are going to receive a uniform pre-phase of vincristine 1 milligrams and prednisone for 7 days, regardless of which arm they're assigned to. And this was due to the fact that in several studies, this use of a pre-phase in this population has been shown to improve outcomes. So this is now mandated. And then we did add one additional time point for a geriatric assessment based on some of the feedback we received. Next slide. So just a few words about the geriatric assessments. I think this is one of the things about this study that's really powerful. It gives us a chance to really learn about this population. So we have a very comprehensive CGA or geriatric assessment. This is actually came from our Alliance colleagues, and this one takes about 20 minutes to do. There's both a patient and provider component. So this more comprehensive one is going to be done at several time points to kind of look at patient overall functioning through their treatment course and their recovery. Are patients just as functional, if not more or less, once they complete treatment? And we thought that that was a particularly important thing to focus in on this population. The other thing is this FIL or EPI or this Italian tool. This is only administered once, and this is to assign patients a status of either fit, unfit, or frail. We think this has prognostic utility, and we hope that our data that we generate here will help us better understand if perhaps this tool should be used in the future as selection criteria for those who perhaps get combined chemoimmunotherapy. Next slide. And so these are my take-home points that I hope will get you excited to activate this at your site. So again, this is the first randomized study ever done in this population, not only in the NCTN, but in the US as a whole. There is now a pre-phase for all. I think that's overall a good thing. It's been shown to improve outcomes in this population. And it also gets around some of these issues about, we didn't allow for a cycle of therapy before patients enroll on study. So this will kind of get rid of some of those biases that can come from not allowing patients to have therapy before they enroll. Their first 40 patients will be part of a safety run-in. The geriatric assessments here, I think, could be really powerful. For sake of time, I didn't talk about the circulating tumor DNA assays that we're incorporating here, but those can help us understand the disease biology, perhaps change outcomes and select therapy in the future, because we're actually going to look at not only the overall amount of circulating tumor DNA, but because we're using oral azacitidine, see if we can look at methylation patterns, for example, in the ctDNA to learn a lot there. And so I think in total, if there's anything to take home, I think this study really has the potential to change the standard of care for patients 75 older in multiple ways. I hope I've conveyed some enthusiasm, and I hope you're all able to consider opening this at your center. And thank you very much for your time.
Thank you so much, Dr. Brown. That was wonderful. I think this is really exciting. And, some of the things that are really unique about this is that it is the first time that these, geriatric tools are going to be applied with a uniform treatment. And, the evaluations are actually pretty straightforward, and a nurse or a data manager can do them. The FIL tool is all electronic and should take about 10 minutes, and it's only done once. And even the serial CGAs, compared to some of the more lengthy evaluations that many other trials have had, I think this one is really streamlined. So, for all of you who are, going to be opening this, I think this is something that we'll talk more about at the kickoff, but this is something that I think can be very easily incorporated into your practice. The other piece is that, I think me included, we struggle with how to treat patients who are older Not only do we not have the tools to know who will or won't tolerate therapy, but there's also data out there that many older patients are undertreated. And, from my perspective, the best agent for curative intent right now remains an anthracycline-based component, even if you can't give full dose R-CHOP. So I hope that this trial will allow us to find that sweet spot, if you will. So I want to thank Dr. Brem for all the hard work, and Kara as well, for this trial. I mean, this was really an incredible amount of work to get from the other cooperative groups, as well as from within our own committee. So thanks so much, Liz.
I'll mention Dr. Smith also has been instrumental in getting this going. It required a lot of negotiation with industry and numerous back and forths that probably are more appropriate to talk about over a few drinks at dinner than this session. But in the end, I think we're really pleased with the way this has evolved and very excited to see it come to fruition. So I really encourage everybody to get this open, and as it's going through IRBs and things, we'll look forward to that kickoff meeting.
I might just ask either Liz or Kara to post the date into the chat box for everybody as well.
We shall. Thank you.
Thanks. All right. I think I'm going to turn it over to Dr. Friedberg. Okay.
Okay, next slide. We'll have Dr. Herrera introduce himself.
Hi everyone, my name is Alex Herrera. I'm one of the lymphoma investigators at City of Hope and the study chair along with Dr. Friedberg of S1826, which is our randomized phase 3 study of nivolumab combined with AVD, or brentuximab vedotin combined with AVD in patients with advanced stage Hodgkin lymphoma. Next slide. So as you all know, this is an intergroup effort. It's really been a fantastic collaborative effort from the beginning, including all of the American adult cooperative groups, as well as the Children's Oncology Group and the Canadian Cancer Trials Group. Next slide. So this is the schema of the study. Patients with advanced stage, either stage 3 or 4 Hodgkin lymphoma, get randomized in a 1-to-1 fashion to receive either nivolumab plus AVD or brentuximab plus AVD for 6 cycles. And then they get their end of treatment PET scan, and then at the end of therapy, they can receive radiation to the residually PET active areas if declared intent to radiate by the investigator from the beginning of the treatment. The sample size of the study is 987 patients. The primary endpoint is progression-free survival. The projected accrual has been 4 years, but I'll show you in a second that we're well on track to accomplish that, hopefully. GCSF is required for patients who are enrolled to the arm 2 brentuximab vedotin containing arm due to increased febrile neutropenia and sepsis in patients who don't get GCSF who receive that regimen. GCSF is optional for patients with nivolumab plus AVD. And we do have quality of life and patient-reported outcome surveys that are administered at multiple points in the protocol. Next slide. So this is the status of the study and enrollment so far. We've enrolled, this is actually now out of date, it's 3 weeks out of date. I think we're up above 420 patients out of 987. The list of top occurring sites here is listed, but this is, as you can see, it's really been a fantastic effort from around the country. And we're more than a third of the study enrolled at this point. And then this pie chart kind of shows the different contributions of the different cooperative groups. And I'm happy to say that SWOG is really pulling its weight. Next slide. But so is the Children's Oncology Group. They've been fantastic collaborators in this study. So this is kind of accrual by month over time. And what unfortunately is not here is that the next month, it's not on this graph, March 2021, we enrolled 51 patients. So really, there's a huge amount of enthusiasm, I think, for the study. It's accruing really quite well. And thank you all for your efforts in accruing, patients to the study. I think we're really on track with accrual. Next slide. So some updates. We did have an amendment. Through that amendment, Canada, the CCTG has joined the study. We've actually activated starting to activate sites in Australia and New Zealand through the Children's Oncology Group, and we're hoping to activate Saudi Arabian sites through SWOG. Now a site delegation task log is required with this amendment. We note that we do want COVID-19 infection reported as an AE, through the AE reporting CRFs. We did clarify some aspects of the PROs. We clarified some aspects of radiation dosing, and we did mention some antimicrobial prophylaxis guidelines, as we did have a couple of patients with a PCP pneumonia, which can happen after ABVD or ABD, kind of ABVD-based regimens. And also for patients who have a baseline pericardial effusion, we recommended some additional monitoring, as we did have some kind of flares of the pericardial effusion after initiating therapy on either arm of the study. Actually, this is kind of a known phenomenon in this entity in advanced stage Hodgkin lymphoma. Next slide. All right, and that's all I have, and I think we'll answer questions, I think, at the end, but I'm happy to have questions.
Yeah, no, I think I'll just make a comment, and then if people have questions, I think we can try to answer them or
Okay.
respond to them now.
Great.
People may have seen in Blood a study of pembrolizumab in AVD that came from our colleagues at Northwestern. This was a more pilot study. It enrolled about 40 patients, and I think less than half of them had advanced stage disease. But the outcome was unbelievably good. There were no events, and the tolerability was very favorable. So in my mind, that has only increased the enthusiasm of giving checkpoint blockade upfront. There are also some genomic studies that are really suggesting that patients with Hodgkin lymphoma, the mechanism of checkpoint blockade is unique in the upfront setting as compared to the relapse setting where it's being used now. So I think both the biology as well as clinical experience are only adding to enthusiasm for this study. And of course, it's not an approved regimen, so this is the only way that patients can really get this. And those who are not getting this are getting cutting edge therapy with the brentuximab combination. We've been very pleased with Accrual, but we would like, to continue to encourage those sites that haven't opened it to open it. Any questions or concerns that have come up? And the study is, of course, being monitored carefully by the Data Safety Monitoring Committee. And we're monitoring for adverse events as well. We have seen through the questions that have come through, as expected, some immune-related adverse events that thus far have been managed in a relatively straightforward way. All right, well, if there are no questions, I think, Dr. Barr, you can introduce yourself and start.
Thank you. So Paul Barr, quick update on S1608. Next slide, please. So you've seen this schema before, hopefully. This is the randomized phase 2 study enrolling patients who have either refractory disease or have progressed after their first induction regimen with chemoimmunotherapy. They have to progress within 2 years of bendamustine or CHOP-based therapy and are randomized to one of the 3 regimens below. And it's important to point out that the translational objectives are to really understand who these early progressing patients are, and perhaps to get an idea of which patients should be treated with each of these regimens. Next slide. So I'll be brief. Again, there has been a lot of discussion given that this is a rare group of patients, challenging to accrue to studies, whether we should deviate from this early progressing group. And I think the group on the SWOG committee on the call especially was very supportive of staying with the original study goals to focus on the patients that progress early. So here's a quick summary of the eligibility: patients with low-grade follicular lymphoma or grade 3A disease who have progressed within 2 years from the last dose of their first-line regimen. It's important to remember that patients don't have to be registered within 2 years. So if a patient progresses and you observe them for a bit, they're still eligible. These patients can have received radiation, maintenance anti-CD20 therapy, or even, say, rituximab before R-CHOP or R-bendamustine. Next slide. And as I previously mentioned, the translational objectives are key to this study and will teach us a lot beyond just the clinical outcomes. We are trying to capture all of the diagnostic follicular lymphoma specimens, as well as a biopsy confirming relapse. But there is language in the protocol allowing folks to enroll patients with less tissue from diagnosis, or if it's not safe for the patient to undergo a relapse biopsy, the patients are still potentially eligible. If you look in the protocol, it basically says to email myself, Chris Flowers, or Brian Link, and we can talk through it, and likely we'll let the patient enroll. So trying to be flexible for this rare group of patients. Next slide. So here's where we stand. This is the accrual data, similar to what Alex showed for the Hodgkin study. As you can see, in the dead of winter, accrual really ground to a halt. It's picked up a bit since February. 2 patients were accrued in March and 2 in April. 2 of which were from the academic institutions represented on this call, and 2 were at community sites. And it's been somewhat impressive that the community sites have been very supportive. So again, if you work with community sites or work at a community site in your region, consider this study. It is very feasible to conduct. Otherwise, I wanted to point out that if we do accrue, say, 2 or 3 patients a month, it's still a very feasible study. We're in the process of amending it, as I mentioned, to reduce the sample size to about 100. And at that level, we'll still have sufficient power to gauge which of these induction regimens might be best for this patient population, and also to in a translational manner, understand who these patients are at diagnosis potentially. So please continue to consider this study. Appreciate all the efforts, and happy to take questions as they arise. Folks have been pretty good about emailing me, and Brian and Chris have been active too in helping to respond. So I still think it's a very valid question, albeit for a rare and challenging group of patients. Next slide. So I think that's it. If there's any questions, feel free to reach out. Sony asked a question about doing routine scans at 2 years in high tumor burden follicular lymphoma. And as you all know, there's been a big push not to overdo CAT scans in our patients after they finish treatment. Personally, I think it is reasonable to do a CAT scan in 2 years or less after finishing induction therapy, given that these patients do have poor outcomes. And we've even seen this in the study. These patients continue to have very difficult to treat disease. So it's something to consider for your patients. If they're finishing, say, bendamustine or rituximab, doing a CAT scan, say, just under 2 years after finishing that regimen, it is something to consider.
I think that's really an excellent point, in that you may not know who these patients are if you don't look. And similar to what Dr. Stevens presented at the beginning, you have to do the risk stratification in order to understand who's eligible for the study and who's at high risk. I think this is the same situation. And you know, if you catch a patient at say between 18 and 24 months who's beginning to progress and they may be asymptomatic, we now have something that we can offer them that we're hoping may change the natural history of the way that aggressive disease behaves, and also really teach us how to manage these patients moving forward. And when people ask our site why we've been so successful at accruing patients, I think that is one important ingredient, that we're hyper aware of the importance of understanding who these patients are, and we're looking for them actively.
Hildy, thank you for putting that comment in. There's always concerns about extra scans, and again, as we just heard, I mean, this is really important. I think it actually makes a lot of sense, to be able to do this more routinely.
I mean, the overall survival curve of the patients who progress within 2 years is inferior to diffuse large B-cell lymphoma, mantle cell lymphoma, and a lot of other diseases where we're doing imaging much more commonly and actively. So I think we're looking for that subset of patients to favorably intervene. Just watching the chat here. Any other? All right, I think we can maybe go to the next. And I think Dr. Stevens doesn't need an introduction.
Yeah, thanks. I'm going to keep this very short. I'm going to update on the S1925 study, which is for patients with acute T-cell lymphoblastic lymphoma. You could go to the next slide. So this study, it focuses on a drug called OBI 3424, which is a nitrogen mustard prodrug. There's a similar drug called PR104 that has high activity against T-cell ALL and xenograft models. So this study, the S1905, is a phase 1/2 study in relapsed and refractory T-cell ALL. The phase 1 portion is focused on safety and determining maximum tolerated dose. The phase 2 portion will focus on response rate, including complete response rate. The eligibility briefly for this study is these patients need to be relapsed and refractory. They need to have prior nelarabine, no CNS involvement, cannot have chemo within the last 2 weeks, and they have to be at least 90 days out from allogeneic stem cell transplant with no significant GVHD. The treatment regimen for this, the drug is given intravenously on days 1 and 8 of a 21-day cycle. These cycles will continue for a maximum of 17 cycles, and the phase 1 portion is using a 3x3 design. This trial did open to accrual in August of last year, and it looks like they have accrued 2 patients at this time. The main PI on this study is Dr. Anjali Advani at Cleveland Clinic, in case you guys have any questions about it.
So here's a challenge for our AV team here. I'm wondering if we could add a polling question, and it doesn't have to be immediate if it takes time to put together, to just ask, do you treat lymphoblastic lymphoma? Yes or no? I'm curious on our committee how many people do treat this. If it's a reasonable number of people who do, I think we're going to continue to try to cover this. My sense is that in many places this is under the auspices of leukemia, unlike CLL, where it's clear that many CLL centers are in lymphoma. So I guess Kara and team, if we're able to figure that out, let's try to put a polling question in at some point moving forward. But if there are no other questions for Dr. Stevens on this one, we can go to the next. Oh, there we go. Let's do the polling question and just see.
That's fantastic that they put that together so fast.
Right.
Wonderful.
And we don't need 5 minutes to answer this one, so I don't know, you could probably close it very soon, if that's possible. All right, well, a lot of people didn't answer, but for those who did, there are 10 people who do treat lymphoblastic lymphoma, and the rest do not. So we will continue to certainly mention this in our sessions. All right. And more power to you for treating that disease. That's a real challenge. Next slide. All right.
This is mine, Pat Stiff.
Yes.
So this is the Alliance 051301, and it's endorsed by BMT CTN as 1201. And this is the randomized maintenance, if you will, or consolidation for ABC DLBCL auto transplants. And again, we're trying to determine if maintenance, or if you will, consolidation therapy after auto transplant improves survival or progression-free survival like it does for Hodgkin's disease, like it does for multiple myeloma. And as people know, the ABC subtype of DLBCL responds approximately 45% of the time to ibrutinib as a single agent. So the notion was minimal residual disease after auto transplant, add in an agent like ibrutinib with a 50-50 chance of significant disease for people with truly refractory disease will improve outcome, especially when given in minimal residual disease state. So patients referred for auto transplant, we initially required PCR evaluation for ABC subtype and did a lot of these analyses, unsuccessful in selecting a large number of patients for actual randomization. So we decided to do the immunocytochemistry or the Hans algorithm for this. It's very quick, it's very easy now. The amendment was, as you can see there, in May of 2019. So it's been 2 years, and we'll go over where we are right now. So you send either unstained slides or stained slides with the appropriate immunocytochemistry to Eric C. at Cleveland Clinic, and within days, literally days, you'll get your answer. So you can do these even if the patient's been referred to you and is already completed or is completing their salvage chemotherapy. During your workup, you'll have the results, and we've been able to do that for our patients here. So the patients are randomized to a typical SWOG CBV or a beam autograft with ibrutinib during the prep regimen, and then for 12 cycles, monthly cycles after engraftment, or a placebo. So it's a randomized placebo-controlled trial. If patients relapse, then they can go on to get active drug. Next slide. So this is the latest update as of March 2021. As you can see there, before Amendment 6, which is when we were doing the PCR analysis of ABC subtype, at 229 patients, but only 28 actually made it to transplant, so a little more than 10%. After Amendment 6, we're not doing as well in registering patients, but as you can see here, more than 50% of those that were pre-registered and were ready to go on to the study actually were registered. And some of these people were registered before salvage chemotherapy, pre-registered before salvage chemotherapy, and not everybody, of course, responds to have at least a PR and is eligible for transplant. And then again, there are a few patients that ultimately are determined even by immunocytochemistry not to be positive for ABC. Next slide. So here's, unfortunately, the sad story. The pre-registered, or those that are submitting their pathology slides, we'd like to see about 8 of those per month. We'll come back to that in a moment. And then again, if we can get about 6 patients actually registered. We had a little spurt after things started opening up in the summertime, and then it's kind of dwindled down again. We're not totally clear why this is. Obviously, people talk about CAR T cells. There's been 3 studies comparing transplant to CAR T for high-risk patients. Many of these patients on this trial would not have been eligible for CAR T because they have chemosensitive disease. As of March 10th, we have 80 patients. 60% were actually randomized. And overall, for the beginning of this trial back a few years ago, 25% of the patients have been randomized. So we're doing much better at randomization. Next slide. So accrual was picking up after Amendment 6, which again uses immunocytochemistry to define the ABC subtype. However, it seems to be stalling again. We need 6 randomized patients per month to complete the study enrollment in 3 years. With even a 25% drop, this means that 8 patients would need to be pre-registered for the trial. It takes only 5 days to get your slide reviewed, so that shouldn't be a detriment, and please consider this trial. Alliance is looking at the statistics to see if enrollment numbers can be lowered, and they are in the process of doing that, and then we'll submit their revisions to CTUB to see what's going to happen. I quite frankly don't know exactly what to say about the poor accrual. There are these patients out there. There are approximately 50% or so of patients that relapse after frontline therapy for diffuse large B-cell lymphoma. We are not curing all of those patients with upfront therapy, but the numbers are lower. I think a lot of patients are being treated in the community with standard salvage regimens that may be effective for these DLBCL patients, including R-squared, and are getting patients into remission, and perhaps patients are declining referrals to transplant centers. But again, if we look at the Hodgkin's data, we have a 20% improvement in overall progression-free survival, even at 5 years, for those that got brentuximab as maintenance, or about 70% of patients are progression-free at 5 years. You don't see that in patients getting R-squared or other salvage therapies, and there's a lot of them out there now. We all know about them, tafasitamab and polomoisin, and the newest kid on the block just got FDA approved today, which is I'm losing the name. There's so many names.
Lonkati.
Yes. And
Stuximab.
yes, but again, our goal here with transplant obviously is to produce long-term disease-free survival, and you can do that with an auto transplant. We're in the process of sending out more of updates on a monthly basis to folks, so look for your in baskets to be notified on a monthly basis of where we are with this patient. Finally, I do hear occasionally that community centers are sending patients for transplant, and they know about the study. They send the patient to the transplant center, and the patient's not enrolled in the study. If that happens, feel free, or if you are looking for a center that has a trial open and you don't know who's open, feel free to email me or Kara, and we can hook you up, if you will, to a center that's actually enrolling patients on this trial. My email is pstiff@lumc.edu. Easy to remember, patstiff at Loyola University Medical Center. That's it. I really hope that we can keep this going. I think that the concern about this being withdrawn for low accrual, we actually were able to stave off this because of COVID, but as things get opened up again in the next 6 months or so, if we really don't get this going, I'm afraid that we'll never get the answer. Sorry for being long-winded. I'm really passionate about this, baby.
Well, I'm going to give you a couple more sentences, but only a couple more sentences. So I think the mention about CAR T is important, because over that time period, clearly there were more and more centers that had opened CAR T. And I know among your transplant colleagues, there's some vigorous debate about, until these randomized studies mature, what subset of patients you might refer for CAR T versus proceeding with an auto, for example, the very good PR patient to salvage. And I'm just wondering if you wanted to take the opportunity to make a little bit of an argument as to why you might consider enrolling on this study for such a patient rather than giving them commercial axi-cell?
Well, it's a bit of a pain of those who are doing it. It's a bit of a pain getting patients approved by insurance companies, and it's expensive, and especially for some of the CAR-T products have to be done on the inpatient side. If they're Medicare patients, centers are taking it in the short, so to speak. And financially, it's not the best thing. Plus, again, there are significant toxicities, including neurotoxicities. And while many of these patients don't die of this, very frequently they are of such a disability that they have to be transferred to a rehab center. Now, if they're ultimately cured and they get rehab, that's fine. But still, an auto transplant, many of us do these on an outpatient basis. The costs are not prohibitive. And again, if we can see a 20% improvement in progression-free survival, as we've seen with Hodgkin's disease, it's conceivable that the survival rates will be higher. Now, I'll discuss the potential results of the current trials comparing transplant to CAR-T. Many of those trials were in high-risk patients that are not likely under normal circumstances to benefit transplant. So if we ultimately find that these trials are positive for CAR-T versus transplant, you need to go back and look at what patients they were actually treating. We didn't participate in some of these trials largely because we felt that transplant was not appropriate for the subgroup of patients that they were considering for these trials. So again, as you said, Jonathan, chemosensitive patients, minimal bulk disease, auto transplant. And if we can improve on the progression-free survival up to 20%, 70% of these people being disease-free 2, 3, 5 years from now, you can't beat that with CAR-T.
Those were 2 Chicago sentences, I think, but that was very helpful. And I think the point was made in the chat that certainly if a patient progressed after this treatment, many of those would be eligible for CAR-T. So, there may be some sequencing issues as well, right?
Absolutely. Absolutely. It won't prevent you from doing it.
All right. Next.
Hi, I'm Brian Till, not Brian Hill, and I'm going to talk a little bit about ECOG 4151, which is our mantle cell lymphoma study. Just very brief update here. Next slide, please. So this is a study where patients can have, the basic goal is to try to see if we could, patients who are in a deep MRD negative complete remission, which we know if that happens before auto transplant, people do well. In the elderly setting, if they don't get a transplant, they also do well. So the idea is maybe we can spare a majority of patients from getting an auto transplant as consolidation in mantle cell lymphoma. So enrolls any patients under age 70. They can get any frontline regimen that you want, and then after 4 to 6 cycles of that, or during the process, you can submit their diagnostic tissue to Adaptive Biotech for clonal marker testing. They get restaged with a PET scan and bone marrow biopsy. If they get at least a partial remission, you send a blood sample to Adaptive to see if you can detect their clonal marker, which has been identified in more than 99% of patients so far. So the clonal marker, not the MRD, the clonal marker has been successfully detectable. And it's about 77% of patients who are actually MRD negative. So then those patients who are MRD negative complete remission get randomized. They get stratified by MID-BC score and whether or not they got high dose ARC, and they get randomized to a transplant, an auto transplant, standard transplant, like Dr. Stiff just mentioned with Beam, a few other regimens, or no transplant, and then both arms get rituximab for 3 years. Everybody else who doesn't get an MRD negative CR, so if they're MRD positive, if they get a partial response, or they are MRD indeterminate, they stay on study and get an auto transplant and rituximab maintenance as standard of care. Next slide, please. And Accrual is moving along. There's, as of the end of March, there were 353 patients that were assigned to a treatment arm. So about 70, a little over 75% of those were randomized, and we're shooting for 434 total randomized patients. You can see the leading sites there. SWOG could catch up a little bit behind the other groups, but it's Accrual is going okay. Next slide, please. So a couple of updates here. Let me get it. There we go. So there was some, I guess there was some feedback from some of the enrolling docs that they wanted some flexibility about potentially withholding some of the maintenance doses of rituximab for mitigation of COVID-19 risk, and also potentially to allow vaccination. And so ultimately we decided to build in some flexibility there and allow up to 4 doses of maintenance rituximab to be held, and then you still have to give them, but not until the end. So you kind of tack them on at the end so everybody gets the same number of doses. I'm personally not advocating for this practice. I don't think that number of doses of rituximab maintenance is going to really allow enough B-cell recovery to get a good vaccine response. And that's sort of supported by the study that came out in Blood in the last week about from Israel in CLL testing the Pfizer vaccine, where patients who were getting any kind of anti-CD20 antibody within a year, none of them had any serologic response. So, but you can do it if you want to. So we're just trying a couple other reminders from previous meetings. I'll just encourage people to wait until after the white count has recovered after their last cycle before sending the MRD test to try to optimize the denominator and improve the sensitivity of the assay when we're testing for the MRD negativity. If the patient doesn't come to enroll in the study until after they've completed induction and you're trying to get the ball rolling to get them to either transplant or not quickly, you can send their diagnostic tissue and their MRD blood test at the same time. That can help kind of streamline things so you don't have to wait until the results come back for the clonality test. And then finally, there are some patients who, in our experience, who have refused their assigned treatment, unfortunately, after randomization. And so when if that happens, please, they're still on study, so please don't stop following them. We still do want to collect their data and keep them, collect their survival data, and we can do kind of separate intent to treat versus as treated analyses later. So that's all I've got, and please let me know if you have any questions.
So this, I think, really has potential to impact the field. This is a study that only the NCTN could do. And again, any induction treatment is allowed. And it'll be interesting ultimately to look. It sounds like the induction therapies that people are giving are quite efficacious, because you said about 3/4 of the patients are MRD negative at that time point. So, but if it really is whatever your choice is, and as new data may be evolving to come out that are incorporating newer agents into induction, those patients would still be allowed to participate. So this will probably be open for another couple of years, I am guessing. So there's still plenty of time to really get involved, and hopefully, I think it'll be very interesting to see. The primary endpoint here is overall survival, and we'll learn what the impact of high-dose therapy is. Dr. Smith, you want to vocalize that? It sounds like it's important.
Yeah, no, I think when this study first opened, I brought it up at some of our meetings. I was concerned that a lot of patients get referred specifically for transplant, and they wouldn't, really feel comfortable not getting the treatment that they were referred for. But I don't know if it's a shift in how I present it, or if it's a real shift in the patients who are being referred, but the concept of a deferred transplant seems very appealing to a lot of patients. So I think my patients get counted under Alliance because of my structure, but we've put like 8 people on, and it's gone quite well.
Yeah, I agree. I've had people on both sides on the fence. There were some that were sort of wedded to transplant before they came, and they just didn't participate on the study. I've had other people who are sort of reluctant to get the transplant, and they, ultimately say they're willing to get randomized, but they're secretly hoping they don't get the transplant. And then when they get randomized, they unfortunately back out. So that's happened a few times. So I hear what you're saying. I think there are people who are definitely happy not to get the transplant. Hopefully we can identify them, before they commit to the study.
It's the kind of study that I imagine that both the patient and the doctor in each individual case are privately hoping for one assignment or the other because they're so different. But
and I think catching them early on, if obviously if you're a transplant center, you may not hear about the patients until they're done with induction. But for those that you're treating all along, I think starting the conversation early in their course is helpful before they can kind of build in an entrenched preference.
all right. I don't see any other questions in the chat, so let's go to the next one, which I believe is still mantle cell lymphoma. No, Hodgkin. Okay.
Great. I am Jen.
Sorry, we shifted the order. There is another mantle cell one coming.
Sorry about that.
That's okay.
Hopefully it won't
Go
cause
for it.
confusion. Okay, so I'm Jen Amenwell from Columbia University, and I'm presenting an ECOG study, phase 2, brentuximab vedotin nivolumab versus brentuximab vedotin nivolumab and ipilimumab for relapsed refractory Hodgkin lymphoma. Next slide. And this is a randomized study stratified by age or prior brentuximab exposure to these two arms, as I just mentioned, Nivo plus Brent versus Ipi plus Nivo plus Brent. And the primary objective is to look at complete response rate in these relapsed refractory patients and to look at progression-free survival, overall survival, and duration of response. Next slide. So fortunately, this study is very close to completing enrollment, and it will be close to enrollment June 15th. So far, I think it's even more now, upwards of 190 patients enrolled, and SWOG's had an okay representation in this study. I do want to just emphasize that patients are eligible if they've had only one prior line of therapy. They could not have received prior PD-1 therapy, but prior brentuximab or ipilimumab are okay. It's now open to pediatric groups, so patients over the age of 12 are eligible. And then the rest of the eligibility is pretty standard. They don't allow for vaccines within 30 days, and there is guidance on how to provide the COVID vaccine during the study if patients are interested. I think that's all I have for the study.
Dr. Herrera, do you want to just give a couple of thoughts on, this combination based on your experience?
Yeah, I mean, it's an effective, at least brentuximab and nivolumab together are really, highly effective. I just treated a patient today with this regimen as a first salvage regimen, BV and Nivo, and it's amazing. Like, she's doing well, PET scans in remission. She didn't have to get second-line chemotherapy. It was really lovely. She's gonna go to transplant. The addition of ipilimumab, at least in Catherine's initial study, it looked like the CR rate was quite high. So I think it'll be an interesting study to see how patients do in a randomized way. I mean, there's always this concern about ipilimumab and toxicity, but I think this study will give us hopefully an answer on the efficacy and whether or not the additional toxicity, if it's there, is worth it.
Absolutely. Patients really like the option of chemo-free in first line, and they've been tolerating it well, and the response rates that I've seen have been excellent as well.
Yeah.
Dr. Manuel, is there any safety signal on the IPI arm or not really?
Not really. There haven't been really any modifications based on that.
And it looks like a question coming through quality of life time points. Are there any?
I think they are measuring quality of life throughout the study and towards the end. And so, I mean, I think that will hopefully pan out nicely, again, considering that patients won't require chemotherapy. And some of these patients, are already post-transplant and chemo as well. So, it's really enrolling both first relapse and then multiple relapse patients with Hodgkin lymphoma.
Okay, so this one looks like it's on the home stretch, right?
Yes, it's almost complete.
Okay. And then I know the ECOG, or is it Alliance? ECOG group is leading an effort to follow this study.
That's right. So based on these results, the hope is to have a randomized phase 3 study in for the first relapse setting, and then to also look at the use of transplant, not too dissimilar from the mantle cell trial, to see if it's necessary in these patients that respond right away to sort of chemo-free approaches to Hodgkin lymphoma.
Okay. So some great options for patients with Hodgkin. I think right now both of these studies are very interesting. Next, there is the mantle cell. Is Dr. Spurgeon on?
Steve's covering the hospital, so he asked me if I could present instead.
Fire away. Make sure you introduce yourself.
Hi, this is Anusha from OHSU. I'm one of the lymphoma faculty here. I'm covering for Dr. Spurgeon for today with inpatient service. So I'm going to present his slides for the EA4181 study, which is a frontline mantle cell lymphoma study up to age 70. Looking at 3 different induction regimens. Next slide. Thank you. So the background for this study is to figure out which is the best induction regimen for the younger fit MCL patients. Historically, there have been multiple chemoimmunotherapy combinations, although bendamustine rituximab has been the most widely used one. Cytarabine-based regimens have also been used as a chemotherapy backbone with high response rates and prolonged PFS. But the problem is there's really no standard regimen. One of the other things that we're looking in this study is the MRD negativity to see if there is any relation with MRD negativity and correlation with longer PFS. Historically, MRD negative rates have varied in peripheral blood and bone marrow based on the technology utilized. So there is an effort to streamline that process with both this study and the EA4151 study, which is also an MRD-based study. Next slide, please. This is some of the data we've had from MRD assessments in the past from ASCT MCL younger patient trial and also end of induction MCL trial. From all these slides, what we can figure out is peripheral blood MRD negativity does correlate with the PFS, and positivity does show poor survival overall. Next slide, please. So the study goals are to identify a frontline regimen that achieves high PET-CT and MRD negative rates, and also to make sure the regimen is tolerable for patients. One of the major issues with the cytarabine regimen is you have to admit these patients to the hospital, and they need intense lab monitoring with twice-a-week labs at least because of the cytopenias we see with cytarabine-based regimens. So the goal is to see if we can avoid cytarabine and if the bendamustine-based treatment with the combination of BTK inhibition is more tolerable and does also improve the PET-CT and MRD negative rate. The primary endpoint for this study is PET-CT and MRD negativity rate, and that allows for distinction between regimens that are likely to produce similarly high CR rates. Next slide, please. So the schema for this study is 3 different arms. The patient has to be registered and then get randomized to one of these 3 arms. Arm A is looking at bendamustine, rituximab, and cytarabine combination. So the patients get bendamustine and rituximab for cycles 1 to 3, and then they get rituximab and cytarabines for cycles 4 to 6. For arm B, they get all 4 drugs that are included in the study, and they get acalabrutinib for cycles 1 to 6, and then they get BR plus acalabrutinib for cycles 1 to 3, and rituximab, cytarabine, and acalabrutinib for cycles 4 to 6. Arm C is no cytarabine regimen, and it's only rituximab, bendamustine, and acalabrutinib for all 6 cycles. Patients get PET-CT and MRD testing, which is also the same testing that we use for EA4181. So that facilitates the patients to be transitioned to the transplant study after this is done. The secondary endpoints are 36-month PFS and OS, toxicity, overall response rates, mobilization for transplant, and bone marrow MRD testing and exploratory quantitative PET. Next slide, please. The statistical considerations for this study are looking at efficacy population, and basically all eligible patients that can tolerate transplant or even without transplant can be randomized. And arm A is considered the standard control arm, so the BR for first 3 cycles and cytarabine and rituximab for the next 3 cycles. Assume 75% of these will become MRD negative for a PET CT MRD negativity of 60%, and that's how the numbers were calculated. The study has been enrolling really well. I don't have the updated enrollment numbers for the study, but from the last update, it's almost 200 enrollment. I think that's it, and I can answer any of the basic questions and then can email the study chairs.
Can we just go back one slide? Yeah, so I'll just emphasize, I think it was mentioned that the concept here is that these patients at the end of this treatment can then go on to the study that Dr. Till presented. And, you know, again, the goal of that study is for those patients who are MRD negative to randomize to transplant or not. So a few points I'll make about that is that the baseline assessment that you need to determine the MRD, if it's done for this study, is already done for that study. You don't have to repeat it. So they're really designed to be kind of tandem studies. It's much more efficient. And I recommend for people who are accruing to this study that you kind of present it as a package, that the goal here is to get to the MRD negativity. And then the next study is to ask the question, when you're MRD negative, what's the best way to treat the patients? And that's one of the nice things about this design. There was a question that came through the chat about, and you may not know this, and I don't know if others have experience, whether the cytarabine containing arms have a higher dropout rate because of toxicity differences compared to the arm C.
I don't know about the dropout rate, but personal experience, those patients do have more count issues and they have to come back and forth for potential blood transfusions, which has been a quality of life issue for some of the patients I've enrolled on this study. And that has been historically the case with cytarabine-based regimens.
It's interesting, the data with cytarabine, of course, was compared to CHOP, which I think has evolved as really not being terrifically effective in mantle cell lymphoma. And I really don't think it's known how important cytarabine is in the setting of bendamustine. And this will, at some level, answer that to some degree. All right, sounds like this study is doing well, and I think we have some reasonable SWOG accrual on this study. So I encourage people to continue to participate. All right, next slide. There we go. And it looks like you're on again.
Yes, this is me again.
Okay.
Talking about the Alliance study, randomized phase 2/3 study of venetoclax in combination with chemoimmunotherapy or chemoimmunotherapy alone for MYC/BCL2 double hit, and also MYC/BCL2 overexpression for the double expressing lymphomas. Next slide, please. So the rationale for this study is to see if addition of venetoclax will improve survival and complete response rates in patients with these high risk markers. Unfortunately, with the double hit arm, we have seen some excessive toxicity in terms of prolonged neutropenia and sepsis rate, and that has been on hold for enrollment for a few months now, and we're still working with CTEP about modifications for that arm. So currently only the double expressing lymphomas arm is enrolling. And the schema for that is once they're randomized, these patients get R chemo versus R chemo plus venetoclax. And R chemo for this patient population is R-CHOP, and IT chemoprophylaxis is allowed in this patient population. The eligibility criteria is double expressing lymphomas, high-grade lymphoma NOS with both MYC and BCL2 expression. MYC cutoff is 40% and BCL2 expression is 50% by IHC. No prior treatment is allowed with the exception of corticosteroids or a single cycle of R-CHOP or DAE-POC. No active heart disease or LVEF has to be greater than 45% because of the anthracyclines, and patients cannot have a CNS baseline involvement. And the lab requirement is pretty standard with platelet count of greater than 100,000 and ANC greater than 1,000 with creatinine and bilirubin requirements. Next slide, please. The enrollment for double expressor lymphoma arm is going really well. As of last month, March, it is 82 out of 107 patients that have initially been discussed. We may have to, however, increase the sample size, and there is discussions with statistics going on in that front. And that's because the initial numbers have been developed based on the historical data for double expressors, which have now improved with R-CHOP and supportive care. So there is some feasibility to increase this, and that's still pending. The double expressor arm, as I mentioned, is still on hold because of the 5 deaths from septic shock secondary to prolonged neutropenias and the DAE-POC venetoclax arm. Next slide,
Double hit
please.
arm.
Double hit arm, sorry. Thank you. Couple of updates for the double expressor arm is 2 patients on R-CHOP plus venetoclax have developed PJP. So we're encouraging for all the sites to consider PJP prophylaxis for patients who go on R-CHOP plus venetoclax. Please keep sending the stained slides in addition to unstained slides, and currently there are no planned amendments.
Anusha,
that's all I have. Thank you.
Is there any discussion about, maybe going back to venetoclax R-CHOP for double hit? It may just be that we don't need, EPOCH-R is a more complicated regimen. It's a more intense regimen, obviously. So if Ven R-CHOP has efficacy, maybe that's what we need maybe that's the intensification.
There are ongoing discussions for that, as well as decreasing the venetoclax and the dose escalation criteria for EPOCH. But the tricky point right now is that no matter what we change, we would have to rewrite the whole protocol, and that's where most of the dilemma is can we use any of the data from this study, or do we just have to redo a new study?
Yeah, I mean,
from statistical standpoint, that's been the major issue.
I agree with that question. I've been, in some of the calls that I've had with the leadership of Alliance and ECOG, I've been advocating for that. I think the adaptation of EPOCH in this situation is, of course, based on single arm experiences that certainly look promising. And I think outside of a clinical trial, it's what most of us do. But to say it's a standard is not so clear. And I think there are subsets of patients that we're learning with different translocations and other risk factors, including early stage, as this group has published, that do very well with R-CHOP. So I think that might be it would be an easy way to resuscitate this, but obviously we'd have to get buy-in. Kara, I'm wondering if we could put up that an additional polling question. I'm just curious in the community and broadly if everybody is routinely testing for MYC and BCL2 in the setting of a new diagnosis of diffuse large B-cell lymphoma. So while we're putting that up, if we can, how about admission for arm 1 and 2 versus arm 3?
I think this may be a question for the 4181.
Yeah.
For the
Oh,
switch
yes.
Also, I think that is a good question.
And
We could-
yes, based on the 4181 protocol, the arm 1 and arm 2 admission is recommended based on institutional standards.
And then a comment about, X plus EPOC may be harder in double hit or triple hit group. And I think we've learned that X plus EPOC is just hard. You add a methotrexate to EPOC, it's hard. And the regimen is probably maxing out what you can really do, and even the so-called targeted agents may add toxicity. People can vote on this question. I'm curious if there's a gap in. All right, looks like for those who answered, it's yes. So that's reassuring. I know in our region, sometimes it's not routinely done in the community. Looks like Dr. Goyal, are you able to speak? Can we open up your mic? Maybe not. Okay, we recently looked at a large data set, R-CHOP versus R-EPOC, and no difference in overall survival in double hit and triple hit lymphoma. Details coming up at EHA. So it's interesting. I mean, I think it again speaks to why randomized trials are important. And one of the shames about this double hit closing is that this was the first randomized trial in double hit lymphoma to really help inform us. And it's reassuring at least that the double expressor we're going to learn something about. And I think that's most of the comments. So we have 7 more minutes, and I'm going to ask, is Dr. Hess able to speak? He may not be. I don't know exactly.
He should.
He is. Wake up, Brian.
I'm here.
All right, got to turn on your camera so we can see that you're sitting outside in the sun. I'm wondering if in, let's say, about 3 or 4 minutes, you can just summarize what you've been working on in the CAR-T setting as just, something that the committee can look forward to hearing more details about in the fall.
Yeah, absolutely. So a lot has happened in the past couple weeks, thanks to some conversations that we've had with Rich Little, who I think is on the call too. So as most people know on the call, we've been developing a study in patients who've received CD19 CAR T cell therapy with DLBCL and follicular lymphoma grade 3B. And we're trying to find trying to find a patient population that would benefit from consolidation therapy. And it looks like about 35% of patients with stable disease or partial remission, or have stable disease or partial remission on that day 30 scan. And if you look at that group as a whole, about 20% of those patients probably stay in a remission up to 6 months, 1 year, and going forward. So that's the group of patients that we think we can potentially really help, and potentially really help before they relapse, because once they relapse, they have a terrible prognosis, as anybody knows who treats these patients. So the development of this study has kind of gone through a lot of iterations. We looked at Taflin as a consolidation, Moz-and-Pola, a bunch of different other drugs, and the latest iteration was a Moz-and-Pola consolidation, but we really only have data on 22 patients. So it was going to be a 2-to-1 randomization, and based on conversations with Rich Little recently, we've decided, and we feel like it's a little bit more safe and probably savvy to not only do Moz-and-Pola for consolidation, but also give Mozen as a single agent and Pola as a single agent, and so have 4 different four different arms that you could be randomized to if you have a PR or stable disease at day 30. It would be 30 patients in each arm. Mike and Hung Lee have been really excellent in getting the stats together very quickly. Actually, it's hot off the press today. Mike and Hung Lee emailed Kara and I and Nash and put together these stats. So it's basically ready for submission for PRC review. So we're really looking forward to this new iteration of the study, and think it's probably a lot safer bet in case there's any big issues with Moz-and-Pola post-CAR T. I actually presented at the SWOG imaging meeting right before this meeting with Vulcan, and they seem to be very enthusiastic about having these day 30 PET scans be centrally reviewed. So really excited about the study going forward, and had a ton of help from a ton of people, including Nash, who can't be here today. Yeah, we're very excited.
And just for the broad group who's on the call, just define what you mean by Mozen and Pola.
Sure. Mosunetuzumab, which is a bispecific T-cell engager to CD20, which is on the lymphoma cells, and CD3, which are on the T cells. And giving it after CAR T could be of specific interest because it might bring the actual CAR T cells to engage with the lymphoma cells that we're trying to eradicate. Polatuzumab vedotin is an antibody-drug conjugate to CD79, where it directly attacks CD79 and injects the chemotherapy into the lymphoma cell. So both of those have shown good activity in lymphoma, and Mozen has shown good activity and to be tolerable after CAR T. So we're excited to use both of them.
All right, and it sounds like we're going to hear some more in the chat at ASCO about that combination, which is, obviously we'll look forward to. So that, along with a study that Dr. Persky is helping to oversee, I think will be a large focus at our meeting, hopefully in person in Chicago in the fall. I want to thank everybody for, not just a nice presentation today, which it was, but all the work that's gone into this. I think that we've developed a very exciting portfolio along with some very interesting concepts that I'm optimistic are going to evolve into full studies. So stay tuned, keep up the accrual, and I'll let Dr. Smith sign us out here.
No, I'll just add my thanks to everybody, not only for the presentations today and their hard work, but also for the dialogue in the chat. I think we have a really great and engaged group, and I want to thank everybody who has opened the trials and has worked really hard to accrue. I think we've got a lot of exciting things that are coming up, and look forward to seeing everybody in Chicago.
An appreciation for Kara Laubach with the slides and all of the administrative support that we get. So thank you very much, Kara. Have a great weekend.
Thanks, everyone.
Stay
Bye.
safe.
Thank you.
Bye.